All right, so this is going to be on the oxyhemoglobin dissociation curve. So there's a few reasons I wanted to do a lesson on this, and mainly it's because I went to school to be a paramedic, had a lot of years of experience, and we were taught the oxyhemoglobin dissociation curve, and we passed the exams that had to do with it, and we passed the provincial exam, and most of the people I know, including myself, leaving school, didn't really understand anything about it. We'd memorized certain facts, and it remains kind of elusive like that. A lot of students are taught about it, but they don't fully understand it. So the aim of this is that if you're a PCP student and you've learned this already in school or read the chapters about it, this is to compound that information, make you actually understand it and see the application. And if you're an actual working paramedic, you already have that knowledge in your head somewhere. And this is just a refresher to make sure you understand it or understand it once again and see the application of it. So a couple things we need to go over to even understand the oxyhemoglobin dissociation curve is a little bit of anatomy physiology. And we're not going to go in depth in these. It's just a quick refresher. So the first thing is your body needs to create energy. It needs energy for everything. Okay. So there's two ways that we create energy, which is through cellular respirations. The one is aerobic respiration, which is ideal. That's what your body's using the vast majority of the time. It is extremely efficient. If you have enough oxygen, it's what your body's going to use as long as you have glucose. And it is wildly efficient, like I said. So you have, and you don't need to memorize anything to do with this for most pathophysiology courses, except for the fact that aerobic respiration is ideal. It's oxygen and glucose produce about 32 ATP molecules, which is a ton. And as a byproduct, you get CO2 and H2O. CO2 can easily be expelled by the body. It's expelled through your respiratory system. And so long as you're up on your acid-base balance, that makes total sense. So pretty much as you're creating energy, you are expelling the exhaust, the byproduct of it, almost immediately. And then when you are unable to create enough energy with oxygen, or when you are lacking oxygen, your cells won't just immediately die. They'll switch to a different method, a backup method, which is anaerobic respiration. Anaerobic respiration is not nearly as efficient. And not only is it less efficient, it produces a much more harmful byproduct. So this anaerobic respiration is glucose and lactic acid equals ATP times 2. So it's almost no energy. It's something though. And again, the byproduct is lactic acid. Why do we care about lactic acid in particular? Well, what you're going to come to find is almost all medical emergencies, no matter what they are, and traumatic emergencies lead to a lack of oxygen in cells. Now, it's complicated how you get there, but at the end of the day, it's pretty much always what's happening. So at the end of the day, the cells are going to switch to anaerobic respiration, and they're going to build up huge amounts of lactic acid. Because your body was not meant to be in 100% an anaerobic state, especially not for a very extended period of time. That lactic acid can't just be excreted magically. Can't be excreted through the lungs. It can be excreted through the kidneys to some extent, but what you really need to get rid of that lactic acid is oxygen. So this is more acid-based stuff, but you do need to know that these are the way your cells work, and that whenever you're super ill, pretty much no matter what the emergency is, at the end of the day, at some point, you're going to have a lack of oxygen, and your cells are going to switch to anaerobic respiration. Talk about hemoglobin real quick. You should already know what this is, but hemoglobin binds to oxygen. Okay, cool. The other important characteristic about hemoglobin is it binds and then unbinds to oxygen. It has the ability to change its affinity to oxygen. So it can want to hold on to oxygen very tightly, and then in a different state want to disassociate from oxygen very readily. That's important because hemoglobin would be useless otherwise. If all it did was pick up oxygen but not offload it, then there would be no point to it. You'll see that the relationship between hemoglobin and oxygen is one of the things that is expressed in the oxyhemoglobin curve. It is the ability to understand why hemoglobin in some instances has a high affinity to oxygen and in other instances it doesn't. And That's a dynamic process. The curve will show us how that works for us. Oxygen, how is oxygen transported in your blood? It's pretty much by hemoglobin. Now, yeah, some of oxygen is transported in the plasma, but it's pretty small levels, and it really is not relevant to what we're talking about today. How do we measure the amount of oxygen in your blood? Well, as a paramedic, you don't. We just don't have lab work. If you were to have a patient in a hospital or have access to lab work, which we don't, you would measure the partial pressure of oxygen in the blood. Okay, so then why do we care if we don't have the ability to do that as paramedics? Well, what we do measure as paramedics is SpO2. SpO2 is a reflection of the amount of hemoglobin saturated with oxygen, right? And we want it to be above 92%. Why? Maybe all of you know about that is because that's what the Basic Life Support Standards recommends. So there is actually quite a very strong correlation between O2 saturation and PaO2, meaning you can predict with relative accuracy a patient's PaO2, their partial pressure of oxygen, just by looking at their oxygen saturation. And that's one of the many reasons we care about oxygen saturation as paramedics. It's a direct reflection of that. You should know, moving forward, that with a PaO2 under 60 millimeters of mercury, with a partial pressure of oxygen under 60 millimeters of mercury, you probably cannot perfuse your organs appropriately, which means your organs are going to start to fail. And you'll die, obviously. So we want to never have somebody's PaO2 under 60. Something to keep in mind as we move forward here. Cool. So let's actually just look at the oxyhemoglobin dissociation curve. Super complicated name, but it's not that bad. On the left side, you have oxygen saturation. And remember I said that it could be that it was a relatively accurate predictor of PaO2. Well, on the bottom is PaO2, partial pressure of oxygen in your blood. So if you went and your patient was a transfer and you had labs on them, they'd tell you that the partial pressure of oxygen whenever they took their blood, and they'd say, I don't know, it's 110. So cool. Let's say, just for the sake of understanding, that your patient's PaO2 is 100 millimeters of mercury. Well, when you put the oxygen sat probe on them, let's follow 100 up. The line's already there for us, right here. If you follow it up, it equals about 100% sats. Meaning, as a paramedic, you arrive at some person's house, you put an SpO2 on them. That means that their PaO2, if it's 100%, that means that their PaO2 is about 100 millimeters of mercury. Okay, cool. Good to know. Let's go down and look at 60 millimeters of mercury. Because remember I said that's where we don't really want to go beneath. At 60 millimeters of mercury, somebody's PaO2 matches with about 90% saturation. We'll talk about that later because the Basic Life Support Standards, they have in there the oxygen therapy standard, which dictates how you're going to administer oxygen. That's based on the oxyhemoglobin dissociation curve and the science behind it. We'll come back to that. So at 100 millimeters of mercury, you're sitting at about 100% sats, and at 60 millimeters of mercury, you're sitting at about 90% sats. Why is that important? Well, notice the red line of the curve is pretty well flat on top, right? Why that is cool is because if you drop 10 millimeters of mercury from 100 to 90, let's see where that gets you with sats, right? So if you go relatively straight up, your sats don't really drop that much. You're still sitting at about like 96% sats approximately. If you drop 40 millimeters of mercury worth of oxygen, which is a massive amount, down to a little above 60, your sats are sitting at 90%, which as you know, of 90% sats, 60 millimeters of mercury, that's still acceptable. You can still perfuse your organs. This means your body has a natural buffer zone of about 40 millimeters of mercury worth of oxygen before it's even a major problem for your body. Again, it's not good to have 90% sats. It's not ideal, but you could totally handle it. Okay, that's one thing to keep in mind. That's pretty cool. But notice the red line is not so flat once you go past that line. Once you go past 90% sats in this direction, that line starts to curve like crazy. And actually, it starts to drop like crazy. Well, that's important to us Because what does that represent? Now, let's say you're at 60 millimeters of mercury, and everybody's had a patient with about 90% SATs. If that person loses another 10 millimeters of mercury worth of PaO2, let's see where they're sitting at for SATs. So if we go from 50 up, even relatively, it's like 82% SATs, almost a 10% drop in SATs from 10 millimeters of mercury, whereas before we could go 40 millimeters of mercury without even losing 10% SATs. That's super significant because that drastic drop in the curve continues, meaning the lower your PaO2 gets under 60 millimeters of mercury, the quicker your oxygen saturation is going to fall. All this means is that you are going downhill in a hurry. Much like they say in emergency medicine, pediatrics will compensate and compensate and compensate until they drop. The relationship between oxygen saturation and partial pressure of oxygen is the same way. It will maintain relatively high for a while, and then it'll just start to plummet. Okay. This is just reiterating what we said, but written instead of on a graph. So the top of the curve, just to make sure you got it, between 90 to 100% is kind of a natural buffer zone. And you would have to drop a very large amount of partial pressure of oxygen to get below 90. So it gives you that nice buffer zone. And so long as you're above 90, 92%, we like to say in Ontario, according to the basic life support standards, you're doing pretty decent. You can definitely perfuse your organs. It's generally thought to be not worth the application of oxygen if the O2 sat is above 92%. Once the PaO2 is at 60 millimeters of mercury, now that relationship has changed drastically. A drop of 40 millimeters of mercury from 60 will result in saturation of 35%, O2 sats of 35%, which I've been a paramedic for 11 years. I have never even seen a dead human being with saturations of 35%. So again, you just can't tolerate losing oxygen beyond that point. It just drops like crazy. That's the first real takeaway of the oxyhemoglobin dissociation curve. That's the first thing you should understand about it. So again, buffer zone, and then under 90%, we drop like crazy, right? That's it. That's the first, that's what these lines are trying to tell you here. These purple lines over here, then the purple lines at 90%. And then again, it drops drastically. We haven't even talked about the affinity of hemoglobin to oxygen yet, and we will. But because people get so caught up on right shift and left shift and affinity of hemoglobin, they often forget these simple basic facts that we just went over and how important they are relative to thinking about your patient and providing them with oxygenation, or at a minimum correcting the reason that they're losing oxygen in the first place. Okay, so now we're ready to actually talk about what is a right shift and a left shift and what controls that. So I mentioned before there's physiological factors that are responsible for a right shift or left shift. So let's go over those factors. They're the temperature of the body, the pH of the blood, and 2,3-DPG. 2,3-DPG is an enzyme that you don't really have much control over in your everyday life, and it tends to follow the other two factors. So you'll see once we get into how this actually affects the body that 2,3-DPG will just follow the lower pH and the increase in temperature, or the increase in pH and the decrease in temperature. There are ways to alter your 2,3-DPG, but that's not really going to come into play with any type of actual emergency or medical pathophysiological scenario. It rarely, if ever, is affected by itself. So what you might have noticed in looking at these factors is these factors are generally a direct result of metabolism. Not always, but generally speaking, they're a direct result of metabolism. Because once again, if we go back to aerobic and anaerobic respiration, the result is always acidosis. Even if you're using aerobic respiration, you're still creating hydrogen ions. So that will decrease pH, and since you're doing exercise, it will increase temperature and cause a rate shift. But we'll come back to that. What is a rate shift anyway? Well, remember the red line in the middle of the curve? that entire line can move to the right. That's all you need to get for now. That entire line can move to the right, and if it does, it's called a rate shift. It's also called the Bohr effect. You have to remember that. It's just a memorization game. So if you have a Bohr effect or rate shift, what that means as it relates to hemoglobin is hemoglobin will have less of an affinity to oxygen, which means hemoglobin will readily disassociate from oxygen. And if you think about it, the factors that cause a rate shift are decreased pH and increased temperature and increased 2,3-DPG, which would be the result of increased metabolism. So it actually makes sense. You would want oxygen to readily disassociate when metabolism has increased because you're using more oxygen. And you want more cells to use aerobic mechanism as opposed to anaerobic mechanism. So by increasing the oxygen delivery to those cells, you're hopefully mitigating the acidosis that is going to happen from metabolism. A left shift, far less common, but is still possible, is the complete polar opposite of a right shift. Every single fact about it is the opposite. So a left shift is that center red line moving to the left, and it means you're going to have an increased affinity of oxygen to hemoglobin. And to the extent that it may not want to dissociate with oxygen at all. The factors that lead to a left shift are decreased temperature, increased pH, so moving into the alkalotic state, and decreased 2,3-DPG because that just follows the other two, like I said. So what that means is you are going to hold on to oxygen because in theory, it's not needed because there's not really much metabolism happening. So again, the right shift and left shift is normal. That should be happening on a day-to-day basis. Why then do we care about it so much? Well, what happens if you drop dead and you're in cardiac arrest? Well, none of your cells are getting oxygen. They're all going to switch to anaerobic mechanism. Well, if all of your cells switch to anaerobic mechanism, you're going to become acidotic. You're going to become in lactic acidosis because of the creation of lactic acid with anaerobic metabolism. That shift to the right or shift to the left of the curve is relative to the changing of the factors, meaning it's not just that it can shift once to the right. If your pH keeps dropping, it just keeps shifting and shifting and shifting and shifting all the way across the graph. And we'll learn about in a couple of seconds here why that matters so much. So here is a visualization of what we just talked about. For now, we'll focus on just this center line here. Just mark it in red, which is a person near or in homeostasis. Now, it can move from the center to the right or left, right? Okay. And then the factors I put on the side here. So a right shift will always be due to a result of increased temperature, decreased pH, which is acidosis, and an increased level of 2,3-DPG. So I've been mentioning that 2,3-DPG follows those other two factors. If your temperature increases and your pH drops, you will have a release of 2,3-DPG. If your temperature decreases and your pH rises and you become more alkalotic, you will have a decrease of 2,3-DPG. So that's what I mean as in it follows it. 2,3-DPG will not be the driving factor behind a right or left shift. So let's say you're going to have a right shift. And you'll notice I'm talking about right shift a lot more, and it's because almost every emergency leads to right shift. Not every emergency, there's exceptions to that. But if you were playing the numbers, which you'll find you do in emergency medicine, it's almost always going to be a right shift, okay? So let's stick with that right shift person that we were talking about, just a regular cardiac arrest person, okay? So they're dead, there's no blood pumping, and immediately all their cells are starved for oxygen, and they don't just die, so they start to switch to anaerobic metabolism, and they build up lactic acid, and the pH drops drastically. So say it went down to 7.10, which is very, very low. It can go much lower, but that's still significantly low. So you're going to have a shift to the right, okay? And this is why we care. So this next line is showing you an artificial rate shift. And we'll just say this is our patient we're talking about, okay? So you can notice the line is quite literally to the right. Well, what does that mean in terms of the graph? And what does that mean in terms of our patient anyway? What it means is, if you look at a 50% sat on a regular near homeostasis person, I just say near because you're pretty much never in homeostasis. This person with a 50% sat will have a really low PaO2. So a PaO2 of about 28-ish, okay? Which is a crazy low PaO2. But if his curve is where it should be, and it's relatively in the center, then his SAT's a 50%, he's going to maintain a SAT of 50% even though his PaO2 is incredibly low. That's incredibly low. And that's still like a critically ill patient. Anybody with 50% SATs is a critically ill patient. But here's where the difference lies with that right-sided shift. Let's say you have a right-sided shift and your patient has 50% SATs, and you might be thinking, well, I guess his PaO2 is somewhere around 30, a little bit below 30. Actually, as you shift to the right, even though your PaO2 is higher, so the PaO2 is above 40 millimeters of mercury here, and the SATs are still 50%. What that means is if you shift to the right, you will have a huge decrease in saturated oxygen relative to PaO2. And that's because of hemoglobin's decreased affinity to oxygen. It cannot retain oxygen, right? So again, that right shift, decreased affinity, big time, right? And again, in small, near homeostasis levels, that's okay, and it helps us dissociate, everything's fine. But whenever we get to those crazy shifts in pH that happens with almost all severe medical emergencies, traumatic emergencies, then that right shift becomes super detrimental to the body. Let's say you have a left shift, and again, it's far less common, but let's just say you do. You're going to have the opposite effect. You're going to have an increased saturation relative to a lower PaO2. And that might sound good in theory, because then you're thinking, okay, well, I can make more out of the significantly decreased PaO2. But the problem is, again, with the left shift is there's an increase of affinity, right? To the extent that oxygen will probably not readily disassociate with cells. So the cells themselves will be starved for oxygen. Neither shift is good. And let's go back to a rate shift just to really explore this. If you have a rate shift, you're going to have a decrease in your ability to oxygenate cells. If you have a decreased ability to oxygenate cells, then your cells are going to switch to anaerobic metabolism. If they switch to anaerobic metabolism, they're going to produce huge amounts of lactic acid. If they produce huge amounts of lactic acid, they're going to have a pH that drops. If their pH drops, they're going to have a right shift in their oxyhemoglobin curve. If they have a right shift in their oxyhemoglobin curve, they're going to have, that just keeps going forever and ever, right? A decreased ability to oxygenate cells, and then it just keeps going, and it results in a right shift. So the shift just gets worse and worse and worse and worse and worse until you die. Of course, this person's in cardiac arrest. You don't need to be in cardiac arrest to have a right shift. If you're in respiratory distress for a long enough time, you'll have a right versus left shift. But again, it'll almost always be a right shift. It's possible to have a left shift from respiratory issues, but it's very unlikely. So just, again, it's normal to shift from right to left. We worry about the extreme shifts. We worry about when homeostasis is seriously affected. Back to that 60 millimeter mark. If your PaO2 is at the 60 millimeter mark or lower, a right or left shift means a massive difference between relative SpO2 and PaO2. Your body can't handle that drop. We already talked about that. But your body certainly can't handle a right or left shift when the PaO2 is below 60. Which just kind of re-hits home the fact that we don't let people's PaO2 get below 60. The whole oxygen therapy standard is written around that fact. We don't ever want people's PaO2 below 60. Shifting to the right or the left causes as well, we talked about that, the correlation between the SpO2 and PaO2 to be different. And then, just to mention this again, I know on all the graphs it'll show the center line and then it'll show the right and the left. And it makes it look like you go from here to there or from here to there, and that's it. But actually, that moving to the right or left is not, it is relative to the three factors we mentioned. So as the pH drops drastically low, it will just keep shifting further and further and further to the right, which will hinder your ability to oxygenate cells, and the whole process just is like a circle of death. So again, center line is where you want to be, and the relationship between PaO2 and SpO2 is accurate so long as you're in this center line. As soon as you have a right or left shift, it changes drastically, even if you are above the 90% SAT mark. But your body can tolerate it pretty well, because look, even with a right or left shift up here in your buffer zone, it doesn't cause near as drastic of a difference as it does below 60 millimeters of mercury. And again, it's because the right and left shift is supposed to be a normal physiological process. But as is any normal physiological process, sometimes certain medical emergencies hijack that and just create this circle of death, much like ICP and Cushing's triad. So I've mentioned this before, and it's kind of a trick for getting through school, and I don't like to give these out because you should understand everything. But it is the truth that just about any serious medical or traumatic emergency is going to lead to acidosis. It is very rare that it switches to alkalosis. And I know you think, oh, I know about all these different things that cause alkalosis. That's because they're rare, and because they're rare, people remember them. But they're rare. They very rarely happen. I can't think of in 11 years of a single human being I picked up whose problem was that they were in alkalosis. Respiratory alkalosis, yes, but very rarely metabolic alkalosis. In fact, I can't think of a single time. So I wouldn't normally say this, but if you're a betting man and you don't know what to put on the test, put right shift. It's probably right shift. You should understand it better than that, though. And how do I know that? You'll know by the time you're done your pathophysiology course, everything ends up with a lack of oxygen, right? That's always what the end game is. If you're bleeding to death, you're not going to have enough blood to transport oxygen. If you're in heart failure, your heart won't be able to pump the blood to the cells that need oxygen. If you're in any type of respiratory disease failure, and it doesn't matter what, asthma, COPD, it doesn't matter. Anything you can imagine, the problem is you're not getting oxygen to the blood. Still doesn't really matter. The fact is you're not getting oxygen to the cells. It's all going to lead to lactic acidosis. It's all going to lead to a rate shift all the time. So again, you don't want to put in your head that everything's a rate shift all the time, because you will be wrong sometimes. So you do need to be able to recognize the difference. It's just that playing the numbers, it's very often a rate shift. Again, the greater the drop in the pH, the further that shift will go. So let's talk about the oxygen therapy standard, and maybe you've kind of already figured this out by now. I'm just going to read directly from it for a second. The medic shall administer oxygen therapy using an oxygen delivery system and flow rate to attempt to maintain a patient's O2 sat between 92 and 96% as measured by SpO2. So you should know by now that oxygen therapy is not without negative effect, and it's all about risk versus reward, and we do not take risk unless we absolutely have to in the medical field, least invasive to most invasive. So we are happy if a person's saturation is 92 or above. We don't need to get it to 96, and we certainly don't need to get it to 100%. In fact, there's virtually no benefit to go from 96 to 100%, which is why this is reflected here. Why is 92% our acceptable rate? We already know that from the oxyhemoglobin curve. You have more than enough PaO2, and 92% gives you a small kind of buffer in case things go wrong before you get down to 90%. It is a way to ensure that your cells and more particularly your organs are being perfused adequately without the paramedic going too far with oxygen therapy. Again, below 92% is getting to that 60 millimeters of mercury, and now we want to aggressively probably treat this person's dropping oxygen levels. So any patient you pick up with 92% SATs, it doesn't matter what their chief complaint is. Mostly, of course, there's those exceptions at the beginning of the oxygen therapy standard. Not going to get into those. You must know those by heart. But generally speaking, if their SATs are 92%, they don't need oxygen. It doesn't matter that they feel short of breath. If their SATs are 92%, they don't need it, and you don't give it, except for those exceptions which I've previously mentioned. Under 92%, now they need oxygen. Okay, so let's say you give them a non-rebreather, because sure, why not? There's nothing wrong with that. And it brings their oxygen saturation up to 100%. Well, now you're giving them clearly too much oxygen because they don't need to be at 100%. So then you taper that down from maybe 15 liters to 12 liters, but they're still at 100%. Now you might even elect to remove that non-rebreather and put on something like a nasal cannula at like 4 liters per minute, let's say. And if 4 liters per minute gives you 98% SATs, then you'll drop it down to 2 liters per minute. And you'll do that until you get somewhere between 92 and 96%. So let's move on from oxygen therapy at the basic level. So just giving supplemental oxygen. What else can we do for people who are probably a rate shift or confirmed a rate shift? How do you get them back to homeostasis? Because if you're a working paramedic, you should already know all that about oxygen, but maybe you forgot about the oxyhemoglobin curve and you're wondering, well, how does this apply to me? Luckily, just by following protocols and doing your job in a way that you don't get in trouble, you've already been doing it. But this would just be to understand what you're doing. You're trying to treat the thing that caused the lack of oxygen to the cells in the first place, which equates to whatever your differential diagnosis is, so long as you're correct, which we're generally correct, not all the time, but generally you're correct, and that means you're going to treat the problem. So just a real basic example, you have somebody who's bleeding to death. They were in a, doesn't matter what, MVC, multi-system trauma or whatever, and you're identified that. Well, you can't give them blood, so you can't supplement that at all. But you can keep their blood pressure high enough to perfuse organs. And you can hopefully try to stop their bleeding, or at a minimum slow their bleeding, and control their airway. And by doing that, you're giving them oxygen into their lungs at least. You're keeping their blood pressure high enough to perfuse organs. And you're basically performing damage control. You're not fixing it. Of course, you can't fix anybody in any traumatic situation as paramedic, but you can do damage control to keep them from shifting too far to the right or from keeping their oxygen saturations to drop too low, below 90, hopefully not below 90 at all. And that's different to each situation. So if you go to an anaphylaxis, well, you're going to treat them according to your anaphylaxis medical directive, which will treat the reason that oxygen isn't getting to the cells anyway. But this is why we want to correctly identify the medical emergency and treat it correctly. Because if you don't, then they'll shift to the right. Here's another thing you don't think about much as a paramedic student versus an actual paramedic. A lot of the times, these emergencies have been going on for 20 minutes, half an hour, 2 hours before you arrive as a paramedic. Why is that relevant? Because that shift to the right has been happening the whole time nobody was there addressing this. So when you show up to a respiratory anything patient, so it doesn't matter the original cause of the respiratory distress, but let's just say COPD, and you arrive and they're in respiratory arrest, meaning they're no longer even breathing, they're not dead yet though. Well, now they've shifted so far to the right, it's going to be insane to try to get them back from that. Not impossible, but it's really difficult. The chances of survival decrease the longer you're in that state. What can you do for them? Oxygenate them, breathe for them, ventilate them, intubate them if it's indicated, and treat them for, in this case, COPD, give them salbutamol to open up their bronchioles, and anything you can do for them. So if they're VSA, that's going to be CPR. If it's a problem with the heart, it's going to be ACLS. If it's a problem with certain problems with the lungs, it's going to be either extremely aggressive airway management or just the medications we carry as paramedics, bronchodilators. So yeah, it's dependent on the situation. As a general rule, we actually don't give an alkalotic substance to the patient. It's not that we don't carry it, and it's not that there's certain instances where advanced care paramedics will give sodium bicarb, but the evidence for sodium bicarb is not very good at all. And the instance when we can give it as a paramedic is very particular. You have to be as certain as you can be in the pre-hospital field that your patient is completely metabolically acidotic. And you might think, especially if you're not a paramedic, that's not possible. There are certain situations where it is possible. So for instance, cardiac arrest with an ongoing time of above 20 minutes, it's safe to assume your patient's in metabolic acidosis without blood work. He's been in cardiac arrest for 20 minutes. So there's exceptions to the rule like that, and that's just about the only time you'll see us give an alkalotic drug. And even then, like I said, there's not much evidence to suggest it helps that much. So again, it comes back to oxygenating those cells, which will be different for each patient. And if you don't do it, or there's a delay to doing it, the situation with the oxyhemoglobin dissociation curve is only going to get worse and worse and worse. And that's why, too, sometimes, especially if you're a working paramedic, you did everything right and you followed all your stuff, and they just got worse anyway. You saw no clear indication that anything you were doing was helping. Well, again, everything's working against you when time has gone on that long, and they've shifted so far right. Just a quick recap. Aerobic respiration is happening the vast majority of the time. The vast majority of the time, it's the vast majority of metabolism. And there's small breaks in that where anaerobic respiration takes over. Anaerobic respiration will take over completely if there's no oxygen. Pretty much every medical and traumatic emergency will lead to a lack of oxygen to cells, which will lead to anaerobic respiration, which will lead to lactic acidosis. This isn't an acid-base balance lesson, and so I didn't cover every single way to end up in metabolic acidosis or metabolic alkalosis, and there's many, many ways. And I don't want you to get the impression you can't end up in alkalosis. It's much rarer. It's often due to the ingestion of substances. It's just significantly rarer. And when we talk about the oxyhemoglobin dissociation curve, it's almost always going to be relative to shifting to the right. All right, let's give you guys a actual college question example. And it's an AEMCA style question as well. But your college really should be giving you these types of questions to prepare you for the AEMCA. So it's a scenario-based question. And the point of this is not to tear apart AEMCA style questions. That is a service I provide. That's not what we're doing here. Okay, so this scenario is long and full of information like any AEMCA style question. And generally you'll be asked 10 to 20 questions about this scenario. And you will have to learn to decipher information within here to determine what's happening with your patient. Rarely are you going to be asked, and specifically on the AEMCA, almost never will you be asked a specific thing like the oxyhemoglobin dissociation curve is this. A 90% SAT equals this. They'll almost never ask you questions like that. They're always functional. Meaning, here's a scenario you would encounter at work, generally based on actual scenarios paramedics have experienced. And then they'll give you a question formatted like that. So that's what I'm going to give you an example of. You arrive to the scene of a 16-year-old male involved in a low-speed MVC. The patient is very scared as he destroyed the front end of his father's new sports car. Airbag has been deployed and there is a fine powder hanging in the air. I'm not going to go through it, but I'm just going to record some things that are super important. Actually, that's not important. It's more this part of that sentence. Patient is in the tripod position in the front of the car. You note accessory muscle use. Patient has blue fingertips. Patient is unsure of his medical history, but states he was prescribed salbutamol. He doesn't have it. Physical exam reveals the following. He has wheezes in his apices and absent air entry in the bases. His vitals are tachy, labored breathing, that's tachypnic, normal GCS, slightly high BP, low SpO2, and high EtCO2. Again, I'm not going to get into it, but what this is a patient with asthma having an asthma attack, probably for some length of time based on the way he's presenting, and he has no air entry in the bases anymore. Okay, so how would a college or AEMCA style question ask you about the knowledge you attained on the oxyhemoglobin dissociation curve relative to this. There's the true or false method, which colleges must use to some extent. So you'll see that your patient has been in this state for 20 minutes. Now, this part of it, patient has been in this state for 20 minutes, they don't have to put that there because you can infer from the scenario that it has been a long time. When I taught at college, I always did this because it just makes it slightly fairer. And you really, really have to be fair when you teach at a post-secondary education because students can challenge anything. And if you challenge it and it's even the slightest bit unfair, you will win. So by putting this here that the patient has been in this state for 20 minutes, it gets rid of any thought process that, oh, this just happened, so maybe he didn't have a shift in the oxyhemoglobin dissociation curve yet. Now you know for sure he had enough time for that to happen. You suspect the patient's hemoglobin has an increased affinity to oxygen, true or false? Okay, so then you have to think, well, what do they mean? Well, you know what instances cause an increased affinity to oxygen. It's a left shift. Okay, what are the factors that cause a left shift? Well, it's decreased in temp, increase in pH, and decrease in 2,3 and DPG. Okay, this patient has asthma. He's having a hard time expelling gas. We know that because his EtCO2 has climbed to 65. And he is also having a hard time acquiring oxygen. We know that because his sats are 90%, plus his actual physical presentation. It is safe to assume that he is moving into a slightly acidotic state. Certainly he's in respiratory acidosis, and he's probably ending up in metabolic acidosis. Okay, so again, acidosis is a lower pH, which would suggest a right shift. A right shift is associated with a decreased affinity of hemoglobin to oxygen. Therefore, the question would be false. If this is the type of thing you didn't study or understand, you'd probably have no idea what to put for this question. Luckily, true or false are a 50% chance of being correct anyway, but you don't really want to go through the program that way. You certainly don't want to be a paramedic with that logic. So let's move on to a multiple choice, which is almost all of your questions. Your patient has been in this state for 20 minutes. You suspect the following. Patient is currently experiencing a right shift on the oxyhemoglobin curve. Okay, so it could be a right shift. Patient is currently experiencing a left shift on the curve. Okay. Patient is in homeostasis regarding the oxyhemoglobin dissociation curve. Not impossible that that is the correct answer depending on the scenario, but probably not. Patient is experiencing root effect. Well, something like this is a clear detractor. However, you would be surprised the amount of students that pick this because they didn't study, didn't prepare, and they remembered the teacher saying something about an effect, and they go, oh, root effect, that sounds right, and they just pick it. Okay, that's a good way for your teacher to find out who is paying attention and who is really not paying attention at all. So it really comes down to A or B, which is right shift or left shift, which comes down to your ability to understand the pathophysiology of this patient. Again, we said he was an asthma guy. We said he'd been breathing like this for a long time, not exchanging gases, retaining CO2, not enough oxygen, probably switching to anaerobic metabolism, and therefore his pH is dropping, which again suggests a right shift. So the answer would be A. Here's another question, completely different question regarding the same stuff. You notice the patient's EtCO2 is, actually that should say 65, but it doesn't matter. The point is his EtCO2 is high, and his SpO2 is low, 90%. You suspect it will be difficult to correct patient's breathing due to the following effect. Okay, really worded difficult here. This question doesn't tell you that this is about the curve. Why would it be difficult? Well, the patient has a right shift of the oxyhemoglobin curve, causing a decreased affinity of hemoglobin to oxygen. Or the patient has a left shift, causing an increased affinity. Or the patient has a right shift, causing an increased affinity. Or the patient has a left shift, causing a decreased affinity. What is the point of this question? You will see questions formulated this way on every subject matter. What this does is make it incredibly difficult to guess because now every single variable is represented. So you really just need to know the answer. If you don't know the answer, you have a 25% chance of getting it correct and a pretty good chance of not getting it correct, right? Because you have every single possible thing here. That's why reading and comprehension is so important for the AEMCA as well, because the questions are super tricky like that, and these aren't even that tricky questions. You'll see when you go on the website, some examples are just insane. But the answer is a right shift with a decreased affinity. Now let me actually think about that and make sure I'm right before I click on it. Yeah, I'm right. I've been teaching this for a long time. I've been a paramedic for a long time. I test myself on this subject matter relatively often, and I still have to think quite a bit before I answer this because it's tricky. And when you're doing an exam, especially like the AEMCA, where you have 150 questions in 3 hours and then another 150 questions in 3 hours, it is really difficult to have the discipline to sit there and go through every single answer here and make sure you're correct. But that is exactly what you have to do to be successful in college and to be successful in the actual provincial AEMCA, which if you don't pass, you can't be a paramedic anyway, regardless of your diploma. Any feedback or comments are welcome. I understand that I do not know everything. That is absolutely the truth. I'm learning all the time. I could have made mistakes in this. This is just to the best of my knowledge from teaching this subject matter, from being a paramedic. Always welcome feedback, comments to get better. If you read about this on your own, the oxyhemoglobin curve gets exponentially more complicated than that, and there's exponentially more uses to it. But I would say that as a land primary care paramedic or advanced care paramedic, there is not much application beyond what was noted here, and I do not think you would ever be tested beyond these capabilities on a provincial exam based on my experience preparing students to write the provincial exam and their success following that. So I hope that you found this helpful. I would recommend taking the mock provincial exam to find out where your weaknesses are.